So I'll just introduce myself for a minute. My name's Julie. I am a nurse. I've been a nurse for 10 years. I work upstairs on the mother-baby side, and then I stepped into the educator role. Is with what I do now. So I get to work with staff. I get to bring in physician-to-physician education. So I get to do a lot of neat things, and that's what brings me here. So I get to do these cool things as well. So those are my certifications up there, and I get really excited about them, so I like to mention them. So today's objectives is we're going to be talking about fetal heart tones, is the overall picture, and how to monitor them. So our objectives is that we want to understand what a normal heart rate is. So sometimes we have to understand what normal is to be able to understand what's abnormal. So we're going to be able to verbalize, hopefully at the end of this presentation, how to categorize fetal heart tones, and then maybe some interventions that we can fix what's called non-reassuring, so ones that we don't really like. So if we can identify it, and we know what's good, so we know what's bad, and then we got to fix it, because that's what we do in medicine, right? We fix things. So we're going to kind of talk about this. This is a really big overview picture. Have any of you guys done OB rounds yet? Yes? Who did you go with? Dr. Green?
I was with Williams for 2 weeks.
Okay, so a little bit. So you got a little bit of it. So you may hear some of the things that are super familiar with us. So so that's what so the first thing I wanted to talk to you about, and I added this in from the last presentation, is we've got a fetal heart rate. But the fetal heart rate can be very dependent on the contraction pattern. So I found a really nice picture of what the blood flow goes to the baby during your contraction. So when you're at your peak of your contraction, there's actually no blood flow into the uterus. So, so babies can actually tolerate 60 to 90 seconds of no oxygenation. So they can tolerate that, but much longer they can't. So as the duration and frequency increases, it also means that we get decreased blood flow to the babies throughout labor. So if we start with labor in an optimal blood flow situation, placental perfusion is more than adequate. But if we've got any kind of pre-existing condition, preeclampsia, gestational hypertension, or gestational diabetes, any of those things going on, we're not in an optimal state, and that's where just 1 or 2 contractions can cause you to have a poor tracing. So that's why we've got to know baby, we've got to know full picture about mom, why it's important to kind of remember that although, you know, mom's in labor, we still have 2 entities that we're treating. So, and when we talk about uterine contractions, when we're looking at a contraction pattern, we actually count your contractions over a 10-minute window, or they average it over 30 minutes when we're doing contractions. And I actually teach prenatal classes, and I like to talk to moms about their contractions as a rolling hill. So you get to a peak and it should get better, it should not get worse. So when I'm talking to them about pain with contractions, is if they're telling me a constant pain, I'm really not concerned about contractions at that point. I have other concerns. So contractions are should always be a come and going. It shouldn't stay with contraction pain. So what is a normal heart rate? So a normal heart rate in a neonate or in pregnancy is a 110 to 160. And so that's the baseline that we want to have a baby in. And you guys, if you guys choose to do fetal medicine or you choose to do obstetrics or anything like that, you'll learn that sometimes your earlier term babies are going to be more in like the 140s to 150s that you're going to Doppel. But sometimes our term babies, so if a mom comes in laboring and she's like 40 weeks or 41 weeks, we may have a 110 or a 120 heart rate, and we're okay with that. So anywhere in there is normal. So we know baseline, that's what we want it to be. So, yep, so I already mentioned baseline. So when we talk about baseline, it's kind of like the flat parts, which is funny because the fetal heart rate isn't really flat. But that's why we want to do it is basically we're going to average it over the 10 minutes, and we're going to exclude the acceleration. So we're going to exclude this, we're going to exclude that. So these are the parts that we're kind of looking at when we're doing a baseline. Can anybody kind of see what it looks like that baseline kind of is?
150.
Yep, 150 to 140. Honestly, a doctor's not going to stress if you put 145. You know, sometimes the nurses will average it. If we're kind of going between the two, they'll say 145. So that's good. So yeah, there's not a wrong answer. If you would have told me 110, we might have had to have talk after class. But no, it's fine. So that's good. So that's our baseline. So we want variability. We don't like flat lines. We like to see that heart rate moving up and down. And so variability, we get, like I said, we want minimal to moderate. Moderate is normal, so we want to see that between 6 and 25 beats go up and down. Absent makes nurses run, makes doctors run. We don't like to see. Sometimes babies will go through sleep-wake cycles as well, so sometimes we'll give them about 30 minutes to an hour of a minimal to an absent, but after that, we're going to do something to get that baby awake or that baby's coming out either way. So that's kind of our definitions, because of course you always have to have definitions, so we know. So does anybody know? So we already talked about normal. So what's bradycardia?
Less than 110.
Oh, yes. Okay, and tachycardia?
Greater than 160.
Okay, yeah. Oh, see, somebody's paying attention. Okay, very cool. So yeah, so those are our definitions for bradycardia and tachycardia. So I'm going to pick on you a little bit because you've done your OB rotation. What might be something that might cause a baby to be a little bit tachycardic?
Cocaine dependence?
Yeah, drug use is definitely good, and that can go either way. It can cause us to have a high, so if mom just used, then we can really see a high fetal heart rate. But a lot of times what you might see is if the mom's water is broken and she's getting the potential of getting like an infection in choreo, mom's fever will go up, heart rate will go up. So a baby, sometimes we see babies when mom has a maternal fever, we'll see babies tap along at 180s, and we don't like to do that for too long. So we really try to control mom's fever, because if we can get mom's fever down, we actually can see the heart rate come back down as well. Okay, so accelerations. The definition is basically abrupt increase, and that we want it to last, accelerations to the peak, in less than 30 seconds. But it must last 15 seconds from basically the whole acceleration has to last at least 15 seconds. And if you're before 32 weeks, we only say that they have to last 10 seconds. So if you look at this little strip here, so this would be an acceleration. This doesn't count because it's not 15 seconds. So we basically have one really good acceleration. So this is, let's see, so each of these red lines are a minute. So that's 1, 2, 3, 4, 5, 6, 7, 8. So this is a little bit smaller than what we would do for a 10-minute strip, but we see one really good acceleration on that, okay? So earlies. So a lot of times earlies are not concerning. Physicians don't get stressed about it. Nurses know that earlies can actually be kind of a good thing. So when do earlies appear? They actually appear when mom is in active labor. If a mom is a primate, which is her first time of a pregnancy, you'll actually see more early decelerations. And then also you can see it with CPD. Does anybody know what CPD stands for? I know it's a big word, that's why I like to say it the way. It's cephalopelvic disproportion. And so cephalopelvic disproportion could be that the baby's not going to fit, that mom's not going to stretch. And so we can also, cephalopelvic disproportion or CPD, or babies that are persistent OP. So we like babies to be OA, we like them to look down, so that the bone, the smushy soft face is on the bone, but if a baby's looking up, that's bone on bone, and that can cause some issues with the babies. So if you've got CPD, you're thinking your baby's got, you're seeing this, you're thinking your baby's got CPD, what might be something that might be a risk of that? So your baby's not going to fit. What's not going to happen? Yeah, baby's going to get stuck. Mom's not going to dilate. So these are the moms you're going to see your earlies on, and you're going to check at 2 hours and mom's 6 centimeters. You're going to check another. So we're in active labor, so that's normal. So your mom's at 6 centimeters. 2 hours later, you're going to check. They're 6 centimeters. 2 hours later, you check. They're 6 centimeters, and they're a little bit stretchy. So you can maybe call them a 6.5 if you want to. So those are some kind of warning signs. You're going to see more and more caput. You're going to see more and more molding because everything wants to fit, but that baby's just is too big. The head is too big. So that's kind of what that stands for. So early can it's normal in active labor, but it's also going to just kind of watch watch the baby just a little bit closer. Okay. So if we continue on our definitions, late deceleration. So late decelerations is kind of more concerning to us. You're going to see a lot more nurses do more interventions for late decelerations. So they're usually gradual. they really start, the timing's a little bit delayed with it, and they start in the middle of the contraction. So when the contraction's at its peak, you're going to start your deceleration. And then when the contraction is over, your deceleration should end at the same time. So that's where we can kind of peg to see if it's a late deceleration or not. So some causes that could potentially cause late decelerations is it could be uteroplacental insufficiency, a diminished blood flow. So if we've got a cord issue, like if the baby's got the cord, if you've seen a whole lot of births, sometimes they'll have the cord wrapped around their arm and their neck and their leg and everything else. So when those contractions happen, it kind of pinches off those cords. But what we do know about decelerations is we know that there's hypoxia. We know that. So something's going on. So if we see any kind of consistency, if we see maybe one late, or maybe just roll the mom, but we're going to start doing some interventions if we've got some late decelerations, and we'll talk about that in just a second. So variables. So sometimes people get really confused with variables versus lates, because variables can happen at the center of it and end. But the thing about a variable is it's abrupt. It's very sharp. So sometimes the nurses will even say V if it doesn't look like a V. Because again, the late deceleration is gradual, so it's going to make more of a U. So if you see that, it's a sharp decrease and it's a sharp increase. And if we go back one slide, you can kind of see it, that it's more of like that upside down rolling hill. So if it's sharp, you tend to think variable, okay? And so the definition of it with a variable is that it's the decrease is greater than 15 seconds, lasting 15 seconds, okay? This could be cord compression. So if you're gonna, with nursing staff, we may be calling our physicians, or we may be getting concerned that we do have a cord around the neck, we do have a cord wrapped around a body cord or something like that. The further you guys get in this, some of these nurses are amazing. They can see a strip. They're like, that's an OP baby with a cord. I'm like, oh my gosh, it's a squiggly line. How can you see it from a squiggly line? But they know, they can tell because they've been around it for a long time. So when we see variable though, your immediate reaction should be cord compression. So that's what we're thinking. So we'll talk about interventions in just a second. So this is what I kind of like to mention this, and I kind of like to throw it in because this is when mom's not in labor. Sometimes they'll do a fetal non-stress test, and it's not invasive. It's usually they have to be third trimester, which is 28 weeks or greater. We don't want to put stress on the fetus. We want to see how the fetus is going to react in its normal environment, okay? So we'd like to see greater than 32 weeks. We want to see 2 accelerations within 20 minutes. And then that just the definition of the accelerations at greater than 15 seconds with 15 beats above baseline. And then again, the less than 32 weeks has to have greater than 10. So this baby who's not in a stressful environment, we want to see these things on this. So these are also things that you're going to do on mamas who want really low intervention and say they want to go past 40 weeks. You're going to maybe see stress tests done on these babies every couple days just to make sure that that placenta is not wearing out on that baby and that they get good perfusion. Okay, so this is where you're going to sound really cool. So if you haven't done your OB rotation, they all talk about categories of the fetal. So we've got category 1, we've got category 2, and category 3. I had one of the midwives did a really great job of explaining it to me, and I really liked it. So she said basically a category 1 is normal. We've got a normal heart rate. We see variability. We've got accelerations. You can tell a good fetal heart strip. So that's just good. So we know we've got good indication. And she explained it, category 3, which is abnormal, as you're going to have your Brady. You're going to have your tachycardic that you're not going to be able. You've got your recurring lates, or you've got variable decels that you're not able to fix. And we basically need to intervene and we need to deliver. That's category 3. And then she said everything else is category 2. So if you've got occasional lates, if you've got occasional variables, but it's fixing with intervention. So we roll mom on her side and they go away. But then after mom's on her side a while, she starts having lates again. We're going to roll her to the other side. That's category 2. I mean, that's awesome. So it's either immediate delivery, and that's category 3, or it's great, category 1, everything else is category 2. So I thought that was pretty funny. I thought that was pretty good. So, but if you look at that, with the bottom in the blue kind of talks about that we know category 1's getting good at oxygenation. Category 2, baby's okay right now, but we're going to intervene. Category 3 means delivery. We're going to figure it out. And that means whatever we're doing. So category 3 could also be a category strip that's not responding. that for some reason, the lates we're having, the variables we're having, we can't fix it, baby's starting to show signs of distress, it's time to get that baby out. So it can change to a category 3. So how do we fix it? Because that's, you know, that's what we do. We fix things. So how we're going to promote, if you guys look at this, the nurses, we have like 3 main things that we nurses do while we're calling the physicians. We flip them, we turn off their pit, and we turn oxygen on, and then sometimes we'll bolus them as well. And so you'll see very, very similar things in this. So if we're thinking that the baby's having some lates, and so we're thinking that the hypoxia is there, so we're going to lay mom on her side. Is there a side that's better for moms?
Left side.
Yep, left lateral. We want to roll moms to the left side. If the baby will tolerate it, we prefer left side, so we tend to try to put that hip roll onto the right if we can. Yep, we're going to give a bolus. If a mom has pit, mom doesn't get pit. No more pit if baby's having any kind of an abnormal tracing. So sometimes if a mom is in a pushing stage, and we're starting to see this, we will hold pushing, and mom has to push every 2nd contraction, every 3rd contraction, and then oxygen. So that's where those oxygen masks come on, okay? And so the same thing. So sometimes we will do interventions to mom that will cause that hyperactivity, and they'll cause multiple contractions in a 10-minute strip. So we don't really like to see more than 4 to 6 contractions in a 10-minute strip. So if we do, we're going to do something about it. And so that's where the tributylene comes in, because we have created a problem where the baby's causing distress. So that's something we can fix. But same thing, stop, pit, bolus, we're going to left lateral. So the core compression. So that's where those variables come in that we talked about, where we're seeing that core compression. So we're going to do the other ones because we want to promote, but these are some things different. So we may do an amnio infusion on that mama. Again, if mom is at the pushing, we're going to start letting that baby get a break. We're going to let that baby recover. And then we're going to elevate. So this is where the nurse comes in. If we see those nasty, yucky variables that the baby's not responding, we may have a prolapse cord. And I've seen more than one nurse right into the OR with a baby, pushing a baby up off of a prolapse cord. So that's when anytime a mom has her water broken at home, we actually encourage moms to come in and be checked. Even if they're not contracting, for that very reason, is we want to make sure that there's good. I have seen moms come in with their water broken, no prolapse cord, and then an hour later, mom rolls on her side, it shifted the baby because the baby wasn't well applied and that cord slips down. Okay, so that's why we don't really like to mess around with moms having their water broken at home and for them just being at home. We really want them to come in and be seen because we're medical and we want to see. We want to see what that baby's doing. So definitely. So if we're thinking cord compression and positioning and amnio fluid infusion, if that's not helping that cord compression, then we're probably going to end up going to a category 3 strip and we're going to deliver that baby. Okay. So we already talked about that. So, okay, so this is a cheat sheet that the nurses really like. So the physicians may do too, but the nurses gave me this cheat sheet. So I wanted to bring that up to you guys. So veal chopped mine, okay? So the name, the cause, and the management. So they go together. So if you've got a variable, means core compression, we want to move the client, okay? We've got early decelerations, we've got head compression, and we're going to see how mom's progressing. We're going to assume that if we see early, she's in active labor, and we're going to monitor her. And accelerations, okay, we like them. No action needed, but late decelerations, placental insufficiency, and then we're going to start doing our interventions that we talked about, turning off pit, flipping, oxygen, all of those things that we do. Okay. All right. So in conclusion, it's important to understand what normal heart rate is. Again, we can't fix abnormal if we don't know what normal is. The fetal heart strips have the 3 categories. I hope that makes more sense to you guys a little bit, that if you've got like a so-so strip, it's going to be a category 2. So if you've got a good strip, it's category 1, and we deliver category 3. And then if there's any issues, you should have ways to intervene and fix. I hope that makes sense. Flip oxygen, pit off, bolus, that's what we do. And then this is a really great website. So if this is your passion, if you guys are thinking that this is the direction you need to go, this is a wonderful website. It has videos, it has practice to strips, it has really simple definitions, because sometimes your definition is so confusing, you're like, I don't even know what I just read. So it's got really great definitions on it. So if this is something that you're thinking about, Dr. Green, I think, gave me this website. That it's pretty good. I make the nurses go through that when we've got new nurses, that they go through this education as well. Okay? Questions about anything?
You flip them on the left side just because the vena cave is on the right.
Yeah.
Just trying to maintain.
Yep. Yep. We're trying to take pressure off of that.
That's like the only thing I remember from OB class.
Flip them on their left.
But yeah, because it's indicated.
Yep. Yep. That's exactly right. Okay.
It just seemed brilliant when they said that. I was like,
Oh, yeah.
I never would have thought of that, but you know.
Yeah, well, you'll actually, if you do your rotation or you choose this path, you'll see a lot of mamas, they want to lay on their back, and you're going to immediately see a change in your strip, in your pattern, just because all that extra weight, because you not only got that 8 pound, 7 to 8 pound baby, you got your placenta, you got your fluid, everything's laying on that vena cava. Yep. All right.
Thank you.
Thank you.
Thank you.
Yeah. Oh, my references.